Hello, everyone, and welcome to the Zoom webinar, Screening for Liver Disease, Advancing Early Detection in Underserved Communities. This webinar is part of the Tackling Liver Cancer Disparities series with the Health Council of South Florida and South Florida Cancer Control Collaborative. My name is Marissa, and I'm the Engagement Coordinator, Global Liver Institute. Also here with us today is Vicki, who is here on behalf of Health Council of South Florida. She would like to introduce herself and her organization.
Hi, thank you so much, Marissa. So, a little bit about the Health Council of South Florida. We're a trusted regional organization which is dedicated to improving health and wellness in the counties of Miami-Dade and Monroe. And we have been for over 50 years. The Health Council has provided unbiased health data, strategic planning, and community service, as well as fostering collaboration and advocating for equitable healthcare policies around South Florida. As for the SFCCC, it's a voluntary network of healthcare providers, community organizations, and advocates working together to reduce the burden of cancer across the Southeast Florida region. And we're supported administratively by the Health Council of South Florida. And the collaborative promotes education, advocacy, and research to improve access to cancer care in our region. Thank you again.
Thank you so much, everyone, for joining us, and I'll go ahead and give a quick introduction to our speaker. So Dr. Gish is a leading hepatologist who completed his residency at UC San Diego after earning his MD at University of Kansas. He has published over 700 original works, helped advance early detection of hepatitis B and C, and guides global liver health policy. He currently serves as a medical director of the Hepatitis B Foundation and practices across several California clinics. You can find more information on his website. And with that, thank you so much for being with us today, and I'll let you take over for the presentation.
All right. Thank you, Marissa. Thank you, Vicki. Thank you, Nicole, and all the people attending. This is being recorded, of course, for a later share. And we're going to talk first about just screening for liver disease in general. And what I'm going to talk about today applies to anybody, and what the basic rules are. And in general, I like to keep things quite simple as we lead into this, that all adults need to be screened for hepatitis B with what's called the hepatitis B triple panel. All adults need to be screened for hepatitis C with a simple antibody test, and if positive, that reflects to what's called PCR or nucleic acid testing. And what's emerging now is screening for fatty liver disease, what we call MASH or MASLD, very, very long names. We used to call it NASH. I like to keep it simple for fatty liver disease. There's many other forms of much more rare liver disease, such as hemochromatosis, there's genetic disorders, there's autoimmune disorders, but these end up being more of a focused evaluation. So the simple rules: fatty liver, which can be screened with simple blood tests, elevated liver enzymes, abnormal imaging, diabetes, hypertension, obesity, hyperlipidemia. As people fit that scenario of metabolic syndrome, having a very low threshold to assess for fatty liver disease is important. And we'll get back to the tools that you would use for that. But let's now proceed to what happens in a liver clinic when somebody comes in with suspected liver disease. What are different entry points? How does this affect how you're going to screen in a community, a disadvantaged community, a community that has limited access to medical care? How do we make this very effective? How do we make it inexpensive? How do we use easy to access tools? And let me see if I can figure out how to do slide forward. Oh, went too fast. Touch. So when we're thinking about screening for liver disease or who should be tested for liver disease, it could be symptom-based. That means, oh, I've got liver pain, or I have yellow eyes, or I have an unexplained fever. I've got colicky or spasmodic abdominal pain. Risk-based is if people have high-risk behavior, needle sharing, unregulated tattoos or body piercing, sexually transmitted disease, high-risk sexual behavior, heavy alcohol consumption. These are all reasons to go down these screenings for liver disease. And when I talked about fatty liver disease before, Fatty liver disease is an umbrella, and you can either get there through alcohol or you can get there through metabolic syndrome. I mentioned the list behind metabolic syndrome that you need to keep in mind. Obesity, diabetes are really drivers. High blood pressure and hyperlipidemia, of course, you need to be monitoring and be part of that clinical scenario. If people have elevated liver tests on a previous blood test, those elevated liver tests always need to be evaluated. Sometimes it's as simple as just doing another liver panel. And then finally, somebody went to the emergency room. Somebody went to their doctor for abdominal pain and got an ultrasound or received an MRI or CT. And the imaging specialist said, abnormal liver, heterogeneous, suspect fatty change, suspect fibrosis. These are different code words in an imaging test, most commonly ultrasound because it's the cheapest, least side effects, that would signal the need to work up somebody for liver disease. And I'm trying to be socioeconomically blind here. I want to give you what to do for all patients. So you're going to give your, what you want to call it, your Cadillac or Mercedes-Benz treatment to all of your patients, because what I'm going to describe today is very inexpensive. And I'll talk about dollar costs and how long it takes to evaluate in just a moment. This is a little bit of a longer list. Now, we used to have this screening filter and say, oh, somebody's an immigrant, they need to be screened for hepatitis B and C. But remember, we now screen everybody for B and C. It's no longer birth cohort. It's all adults. Very simple testing. Costs maybe $50 to do B and C testing, even at a commercial lab. At the bottom of this list is some unusual diseases that can have triggers for an evaluation, but these are all quite rare and don't apply directly to our first level testing. But I want to keep second level testing in the background because we're going to come back to that. Of course, if somebody's jaundiced, you're going to do a big workup. If you feel a large liver on physical exam, and remember, the physical exam is free. A good physical exam probably takes 5 minutes. You look at eyes, you look at skin, you look at posture, you look at how they walked into the clinic, you look at their muscle status. You're going to do a skin exam, heart and lungs. But on the belly exam, on the abdominal exam, you're going to feel for liver size and spleen size. We don't say, like the old days, oh, 3 finger breadths below the right rib age. That's completely out of date. We're going to now say, what is the span of the liver by what's called a percussion exam. And you can measure below the edge and above the edge by percussion. Where is that liver dull? Do you feel a left lobe? Can you palpate the spleen? Now, people with elevated liver tests, I like to strongly recommend that all of those patients have an ultrasound. That is, I think, very important. But this is the reverse. Someone's got an ultrasound or a CT or an MR that shows abnormal liver imaging. It's now time to do the multi-stage workup. You're always going to do stage 1 first, move on to stage 2 if stage 1 is negative. Just keep those 2 phases in mind. There's a family history of liver disease too. You're going to think about doing more extensive workup, including fatty liver runs in families because metabolic syndrome runs in families. Take that history. It's free. Now, here are the 6 tests in a liver assessment that we think about, and a chemistry panel that's going to include almost every one of the tests that I'd listed here is very inexpensive, even commercially, $40 or $60. But what I want to separate out on this slide is the difference between liver function and liver enzymes. A lot of people you'll hear say LFTs. That term is out of date and should not be used. We want to separate the top, as you see here, liver enzymes. Those are not LFTs. Those are liver enzymes. and the bottom, which are true liver function tests. And the two most important on the liver function test is the bilirubin and albumin, because that comes in automatically as part of any chemistry panel. So in all clinical settings, you're going to get a liver panel. The liver panel is going to include a GGT. You're going to look at the bilirubin and albumin. It's part of the chemistry panel. Very inexpensive, and this can be done in many settings, even remote settings. Very inexpensive. The only place where I limit this panel penetrance in terms of my advocacy is in countries like West Africa that are true, very low income countries where people have very limited resources. And we're trying to come up with an answer for them that I'll get to in part 2 of this presentation. So this is a group of Swedish patients, but this really applies throughout the entire world. Elevated ALT, an elevated liver enzyme, and that's one of the ones we look at the most or the strongest. Look at this. Half of the patients have fatty liver. So if you see elevated liver enzymes, you got to think fatty liver. Of course, you're going to take an alcohol history, which is free. There is a blood test for alcohol use or alcohol exposure that's called a PETH test that tells you how much alcohol they drank in the last month. That's getting a little bit more expensive. It's not required up front, but you can take a history, a CAGE history, an audit C history for alcohol, costs nothing, quite accurate, 80% accurate. There's a lot of other more rare diseases, but after fatty liver, you have viral hepatitis, then you have alcohol. Remember, that's the big four that we were talking about. Another example of this spread, in every one of these studies, this is a different study, but giving you the same information. Half of patients, fatty liver, viral hepatitis, and alcohol. That builds the big four. I am going to talk briefly about, in this panel of liver tests, what is healthy. The lab may call it something normal, but a woman should have an ALT and AST less than 25, and a man should have an AST and ALT less than 35. So anything above that healthy threshold is where you're going to start your workup. It's a healthy level, not a normal level. Alkaline phosphatase, we're going to get back to that a little bit later. Another liver enzyme that points to a different pathology, a different diagnostic workup. This just has to do with an interesting number of people who we thought we were healthy because they had been screened to donate their liver for a liver transplant, and they had normal body mass index, normal triglycerides, normal glucose, normal cholesterol. And that's where we came up with this new healthy numbers, 35, 25. Here's 34 and 22. I like 35 and 25 because it's easy to remember. Now, when somebody comes in with an abnormal liver panel, abnormal liver imaging, you need to take this history. This history can take 5 or 7 minutes. It's free. But to be a good provider, you need to take a history. To be a good provider, quality provider, you need to do a physical exam. So let's make sure those are part of your inexpensive workup. Now, I mentioned the big four: fatty liver, viral B, viral C, alcohol, but you need to take a medication history, an herbal history, a supplement history. I worked in West Africa earlier this year. I was on a call just this morning for an hour with a country called Guinea-Conakry. It's also in West Africa. And the number of herbal remedies used in Africa is incredible. People believe in Western medicine, but they believe in traditional medicine. And in traditional medicine, there's a variety of herbal supplements. In the US, we go down the supplement pathway for health, for bodybuilding. And things like green tea extract and turmeric have all been linked to liver injury when they're in high concentrations, especially if they're in an extract form. Well, some people are building their bodies, and that has androgens. These are hormonal supplements that can come in plant form. Or people want to go the other way. They want to lose weight. There's a lot of weight loss treatments that also have herbal supplements as fat burners that have caused liver injury. And then high dose vitamins, like high dose vitamin A, can cause liver injury. So take that history, take that medication history. Super important. This is a long list about alcohol, tattooing, high risk behavior that we've covered, I believe, and I'm going to move a little bit more quickly. This is the physical exam we look for, but the physical examination usually does not become significantly abnormal until very late in liver disease. So a patient I saw yesterday in my federal clinic says, I don't believe you. I don't think I have liver disease. I feel fine. So we had to reestablish a relationship of trust. We had to describe normal and abnormal, healthy and unhealthy liver tests on blood testing. This person also had an ultrasound that clearly showed fatty liver. The person was obese, had metabolic syndrome. So by the end of the discussion, using models of livers. And what I do in my practice is I have these little models I carry with me everywhere. And I talk about what a normal liver looks like, what a fatty liver looks like, and then getting all the way out here to cirrhosis and even talk briefly about liver cancer. Although I really emphasize at the end of any discussion, you don't have cirrhosis. You don't have liver cancer, if that's correct, of course. And I also tell each patient about the stage of their liver disease. So staging is super important. I'm trying to keep this in focus so that I can get that done. So by using this staging model, I can tell the patient where they are on their liver disease journey. So models are extremely important, pictures, diagrams to help your patient on their journey. Free. Remember, most of the things I've described today, except for an abdominal ultrasound, are under $100 for this entire first level evaluation and education package. I mentioned before you want a expensive workup, double check the liver tests. But if you have elevated liver enzymes even one time, you should definitely be doing my first 6 tests. Let's repeat those 6 tests for a moment. Hepatitis B, triple panel. Hepatitis C, alcohol history, fatty liver assessment for MASH, MASLD as we call it. You're going to take an herbal supplement and med history. That counts as number 5. And finally, we check iron levels, especially in North America, Western Europe, where iron overload can be a problem. But iron overload is a problem in Africa. They have a very specific genetic and diet predisposition for iron overload. So these are the 6 tests. We call it 6 tests, 6 minutes, $60. Because basically these tests are all inexpensive, cheap, or free. The hepatitis B triple panel is about $20. Hepatitis C test, about $20. Iron saturation, about $20. The other 3 are free because in the medical chart, typically you have a body mass index. Someone's had a fasting blood sugar or lipid profile at some time. You can get a waist circumference, a blood pressure, and we get a little bit more fancy in the future. We may do something called a fibroscan, but there's 7 competitors in that space, so we don't use fibroscan anymore. That's too commercial. We use elastography and an attenuation score. Those are inexpensive, although the initial investment for that machine can be between $70,000 and $200,000. But one machine can test 10,000 people. Now, I'm not going to go into this slide in great detail because this is where I think hepatology comes in First level workup's negative, then they need to see a liver specialist, because then as a liver specialist, these are all the things I'm thinking about in practice. But what's on this slide is less than 10% of all liver disease patients. So my rule of 6 minutes, $60, 6 tests is going to make your diagnosis in over 90% of people and guide those people on their pathway. And this is very useful even for people who are in remote or difficult settings. The next few slides just talk about liver enzymes, how else to use those. I'm going to move through that because I want to get to part 2 of my presentation. And this slide deck Marissa has, which she can share with anybody. And Marissa, you can post this on your website, send it out as a link. And there's some other descriptions. And I'm going to wrap up this first part of this discussion. We want to be time sensitive for Q&A a little bit later. That there's 2 other enzymes on that liver panel, alkaline phosphatase and GGT. These 2 tests point to what we call cholestasis. That's an impairment in bile flow. The 2 most common to drive up alk phos and GGT are fatty liver and fatty liver. Fatty liver from metabolic syndrome, fatty liver from alcohol. And that's why we say this is a foundation of 4 liver enzymes to set the stage for the rest of your workup. Cholestasis, and I don't want to leave out the gallbladder because that's part of the liver and that's part of how you assess your liver patients. You do want to take a history. Are you having colicky abdominal pain that could support this concept of gallbladder dysfunction or gallstones or a stone in the bile duct? Those could cause pain, cause high liver tests, typically ALP phos and GGT. You have to think 500,000 people get their gallbladder out every year because gallstone disease is so common. So common things occur commonly, but gallstone disease typically is an acute liver change. What we've been talking about today is chronic liver change, chronic liver enzyme elevation. And this is a list of when we think of cholestasis and high ALK phos and high GGT. But if you talk to a pediatric doctor, they're going to laugh at you and you say alkaline phosphatase because they never use alkaline phosphatase if you're a pediatric doctor evaluating liver disease. Because alkaline phosphatase comes from bone and children are growing, their alkaline phosphatase can be through the roof. And that's why we go to this test at the top called a GGT. So this is the foundation. 4 liver enzymes, AST and ALT. That's a hepatocellular pattern. ALK phos and GGT. That's a biliary or cholestatic pattern. So a little bit more on workup, a little bit more on ratio. I do want to highlight that the GGT is a detector of fatty liver and is correlated with people getting heart injury and dying from heart disease. Because fatty liver disease, when you see fatty liver disease, the most common cause of death is heart disease, not liver disease. Second most common cause of death in fatty liver is cancer, many types of cancer. Number 3 is liver disease. So the GGT is a flag to look at the whole patient. Talk about heart disease and heart risk modification. Talk about cancer and losing weight, getting rid of fatty liver. Decreases the risk for many types of cancer. I do want to follow up with a liver function test, the bilirubin. It's our best liver function test. But if the bilirubin is high, we split the bilirubin in what we call fractionation, talking about direct versus indirect. That's a little bit more of a discussion with your GI doctor, your liver specialist, to talk about where is your liver function after doing this chemistry or liver panel. So I think we are going to wrap up with just a few conclusions. Everybody with elevated liver tests needs to be evaluated. Everybody at risk for liver disease, which is all adults, need to be evaluated. Every adult gets a hepatitis B panel. Every adult gets a hepatitis C antibody. every adult, you look for metabolic syndrome. What's their body weight? What's their BMI? Hypertension, hyperlipidemia, diabetes. This puts a very inexpensive package together that allows you to really thoroughly assess all patients for liver disease, what's the cause of their liver disease, which you can see for this inexpensive cost in over 90% of patients. So Marissa, what I'd like to do is stop here, step back and see if there's some questions from our participants. Then I can go into the other extreme. What do you do in a situation where people are hundreds of miles away from easy clinic access? But that's part two. This is a little bit of an intro. I'm going to stop sharing here, and Marissa, go back to you as the moderator to see if there's any questions.
Okay, yeah, sounds good. So if anyone has any questions, feel free to either put them in the chat or just unmute yourself. Yes, Raj?
Hi, Dr. Gish. Thank you so much for the talk. I always love your talks. I try to attend them. I do subscribe to your podcast as well. You make things so simple for us. I just love it. Couple questions for you. One question is about, checking iron. Many times what we have seen is even in patients with MASLD, iron saturation would be high. So like iron saturation would be greater than 50%, and then we do hemochromatosis gene panel and it comes back negative. Do you also follow the same as to if the iron saturation is high, you order the gene panel, or you do not worry about that too much in fatty liver patients? That's question number one. Second question I have about supplements. Uh, is there any supplement that you would tell patients that okay to take, or in your extensive career, you have probably seen DILI or hepatotoxicity from almost every supplement under the sun that you tell them not to take it? For example, many patients use Thrive or Dose, and there's so many other. So just wanted to get your thoughts on any supplements that you
Sure.
tell patients that okay to take them. And second, about the iron saturation being routinely being pretty high in fatty liver patients. Thank you.
Great questions, Raj. Thanks so much. So during an iron workup, since you're doing that in your first 6 tests, and if you have 2 iron saturations over 50%, the next step is not genetic testing. The next step is to quantitate the liver iron. And in the old days, when we were all training, we did liver biopsies. But a liver biopsy is invasive and costs about $3,000. And you have to send the tissue to a lab, and a month later, you get your iron quant back. Not the case now. We send them to a magnetic resonance scan. And again, this is for middle and high income settings, not remote settings. That iron quantification on MR looks at the entire liver, and they do what's called an R2 star. And the R2 star calculates the iron in the liver, and it will tell you normal, indeterminate, or high. If they have a high iron in their liver by MRI, you can do gene testing, but the gene testing doesn't make the diagnosis. The gene testing just tells you whether they have one of the 2 genes that leads to iron overload. There's 5 different genetic disorders that lead to iron overload. There's 3 different environmental types of disease that can lead to iron overload. So it's ultimately what's in the liver. And if it's over the threshold for hemochromatosis, then you intervene with phlebotomy, or in difficult situations, you can use an iron chelator. And the genetic testing is only for screening for family members. If the primary person has it, then you're going to go ahead and screen other family members and make a determination. And the final comment on the iron world is do not order ferritins. Ferritins were out-of-date tests that Bruce Bacon came up with in the 1990s to help us decide who to do a biopsy on. Ferritin was over 1,000. Ferritin is an acute phase reactant, meaning it goes up in any inflammation, and it's just very messy. It's very confusing. So focus on iron sat, 2 times over 50%. Go to MR quant. If you don't have access to MR quant, you can get a liver biopsy. If you can't get a liver biopsy, call for help. Next herbal supplements. The herb I recommend, the supplement I recommend to every patient is 3 cups of coffee a day, or green tea, or black tea. We have proof that the best herbal supplement in the world is coffee and tea for liver protection. Not only is there no danger, but coffee or tea decrease the risk of cancer, of cirrhosis, of progressive liver disease. Liver protective. This came out of the Framingham study and many other studies. It was on the front of Gastroenterology 2 years ago with a giant liver made out of coffee beans, maybe 3 years ago. So we know coffee is protective. The rest of the herbal world, we don't have much supportive data. But I will tell you that milk thistle is safe, but ineffective. 200 studies with milk thistle have shown no benefit, but nobody's died. No one's had developed liver failure. Once you get into the next level, I end up having to read. On my website, there's an herbal supplements that are known herb supplements that are associated with acute or chronic liver disease. There's other websites. I think the Dilly Tox website has it. But what I've seen recently, because turmeric is such a hot topic today, is these turmeric extracts or turmeric concentrates can cause acute liver injury. Green tea extract. I've seen personally over 10 cases, and on the website, the Tox website, the tox.gov, I think is the website, over 100 cases of green tea extract. So you can tell your patient green tea safe, drinking it. Green tea extract, no. There's a number of other common supplements such as scutellaria. There's a number of other verbena that have also been shown to cause liver injury, but a lot of it's idiosyncratic, Raj. So what I do now, and this is very high level workup now that we're talking hepatology, is that if I have an herb, a supplement, a drug-induced liver disease, I do a genetics panel on each of those people because the genetics panels are free. There's 2 free ones on the market, one from Prevention Genetics, one from Invitae, and those genetics panels will tell you why they got DILI. Because people with DILI, almost every single one, has 1, 2, or 3 genetic mutations, such as cystic fibrosis or one of the PFIC, MDR3. There's a variety of genetic mutations, variants we call them, that can lead to a high sensitivity for DILI, HILI, SILI. So it's not just the supplements bad, but it's supplements bad in a person with a genetic predisposition. Otherwise, every person with green tea extract out there would have gotten liver failure or liver injury. It's the trigger and it's the genetics. And this is also true in a lot of more rare forms of liver disease, such as PBC, autoimmune hepatitis. So I'm a geneticist now. I've done over 70 panels. 65 out of 70 have had multiple genetic mutations that would indicate a risk for some type of unexplained chronic or acute liver injury. Raj, I hope that answered your questions. It's a little bit long-winded, but I think that's good for everybody. We are now going to jump from the real world to the real world. And let me get to share. And then let me get to the deck. Hang on just a second. And here we go. I went to a fantastic meeting in Calgary, Canada last year, and one of the speakers shared these slides with me. And Canada is this gigantic space that has very good medical care. But to get medical care, you got to get in an airplane and fly 3 hours over the Arctic tundra. So we're going to talk about what they're doing in Canada, especially because they have this treaty now that brings together all of these First Nation people and providing them with more advanced liver care. So there's a lot on these slides that you can read about and look later. But there is all of this 2-tier healthcare system in Canada, segregated healthcare, all sorts of places where they placed First Nation, Indigenous people into different homes, etc. And Canada has worked very hard on harmonizing their healthcare across this entire expanse. So you can look at the Canadian government statement, and there's a lot goes on in Canada. I go to a meeting there, and they honor the people who lived on that land where the meeting is previously, thinking about the First Nations people, about the people who were displaced. Now, universal health care takes a lot of work. And how did the Canadians really work through this? And they had a challenge. They had H1N1 pandemic, then the SARS-CoV-2 pandemic in 2020. And they started working on how do they get healthcare to these remote locations. So they also were working with WHO on this. On the left side of this is gold standard laboratory testing, right? Someone comes in for a blood draw, you send the blood, you get things quickly, you get them back within days or weeks. The healthcare professional meets with the person comes in and out. But when you have these remote locations, you need point of care testing. And point of care testing is really coming into a first line position for glucose, for cholesterol. Blood pressure, that's point of care. You put on a blood pressure cuff. You weigh the person, that's point of care, and you calculate their BMI. But we need point of care for hepatitis B and C. And back to diabetes, we have hemoglobin A1C. It's a $20 test, finger stick. You can have your results in 20 minutes. So lots going on with point of care. So you can collaborate geographically by sending kits and these point of care kits out to these remote locations. And I'm using Canada because it's right next door. It's part of North America. It's a brother or sister country, works with the US, but it's got a different model. This could be applicable in the US because we have a lot of indigenous populations here, American Indians, First Nations. There's a lot of different names that we use for these people who moved here 15,000 years ago, before a lot of us other immigrants got here. My family came here 300 years ago, but you can hardly call that local on the scale of how long people have been in North America. But look at these little boxes. There's a box by a company called Cepheid called the Gene Expert, and they've got these little kits, a little cartridge, a finger stick, and you can have a hepatitis B test back in an hour. Hepatitis C, HIV, TB, influenza, RSV. I've been working in West Africa, and there's over 20,000 of these machines in West Africa, previously heavily focused on HIV, then TB, then more recently hepatitis C, and moving into hepatitis B. But look at that little kit below, that little white strip in this. That test kit, the materials cost just a few dollars. I don't know what the commercial price is for that in the US or Canada, but there's a strip test that I'm using in West Africa that is 60 cents that detects surface antigen, and $1 for detecting hepatitis C antibody. But for hepatitis B, surface antigen, that's good to go to treatment, although WHO suggests PCR or nucleic acid testing like you see with this Gene Expert. Hepatitis C, you have to have PCR, because if you don't have a PCR machine like the Cepheid, you're not really sure about treating everybody. You'd be over treating people. So you have a strip test, you have a box, and you can get testing into the most remote areas. All you need now is a little investment and some electricity. And even more advanced, at the bottom, they have something called dried blood spot. You do a finger prick, you put it on a piece of paper, you drop the piece of paper into the mail. 2 weeks later, whenever it gets to a remote lab, a test results comes back. You can transmit that result back to a PDA, a phone, a computer, a database someplace. It does take some electricity to ultimately manage all this and air transport. But look what Canada has done in terms of putting out, building capacity and putting these locations and devices and these different locations that you can have access either to a blood draw, dried blood spot, or one of these more advanced machines for testing. So the ability to do this is fantastic because this is where the people are. They're delivering this to these different locations. And here's the gene expert point of care as of last year. Look at all of these machines where you can do all of these testing. And they have even more advanced testing on these gene experts I didn't even describe today. We have a febrile illness panel. They've got other acute panels, emerging infection panels, including for things like malaria. I mentioned TB before. So there's a lot going on here. And the Canadian team is just amazing on what they have done because diagnosis, of course, should lead to treatment, to interventions. HIV, suppression. Hepatitis B, suppression. Hepatitis C, curable. Metabolic disease, you can intervene with diabetes, hypertension, weight loss programs. These are super important. So this just talks about how to manage these disease states. This is an outbreak response, but this is also true for detecting and managing chronic liver disease. So I'm just going to move through this quickly. This is about sexually transmitted. Again, you break that transmission pathway by diagnosis and early treatment. Syphilis, curable. Gonorrhea, curable. TB, treatable. I'm going to call it curable. And we already mentioned B, C, and HIV. So lots going on a coordinated approach. I'm actively working on this in West Africa. I do want to say, if you look at that little strip at the top, that's called OraQuick, and you just wipe it on the inside of your mouth, and you can get a hepatitis C antibody result, positive or negative, on this strip. But if that is positive, you still need a finger stick to go back to do PCR testing for hepatitis C. The hepatitis B world is kind of interesting because all the different guidelines are recommending PCR testing and only treating if the viral load is over 2,000. But I disagree with this approach. I think anybody who's surface antigen positive should be on treatment because 95% of those people are PCR positive with the DNA at different levels, although some of them may be low, but low is never good. Low means stigma, discrimination, infectivity, decreased quality of life, inflammation. So hepatitis B treatment, to my mind, is treat everybody. The guidelines haven't quite gotten there yet because they are so structured, so narrow in terms of their evidence-based. The AASLD guidelines came out last week on hepatitis B, and the key wonderful positive part of those new guidelines is SDM, shared decision making. So shared decision making can be applied anywhere in the world. You have a simple test like surface antigen. Should you be on treatment? You can talk about that because PCR in West Africa is $60. 1 year of tenofovir is $30. So why are you going to spend money on PCR when you could spend money and get 2 years of treatment? So lots of discussion going on, lots of debate, but we are moving the dial where there is a patient-centered approach. And I think that wraps things up. There's this surface antigen test that we talked about. That's a strip-based test that's 15 minutes. And hepatitis B is part of the gene expert now, depending on the country and regulatory approval. So there's still a few barriers out there. But the Cepheid technology is absolutely fantastic and really provides incredible information. I think we've covered everything here. This is just some really good slides and information about how a great country of Canada took their best technology, their best advocacy, their best care to remote locations, which could be really a model for the rest of the world. And I think we have a few minutes left for Q&A. I'm going to stop sharing and let's get back to hot topics.
Layla in the chat So thank you for a wonderful presentation. Besides drinking coffee and tea, are there any other dietary changes you would recommend to help the liver?
So I have this discussion every day with my patients because more than half of my patients come in with metabolic liver disease, fatty liver disease. And I engage with those people with what's called a motivational interview. And I find out what is motivating them to choose unhealthy behavior. They know if they're 300 pounds that something's wrong. They're not eating normally. What's in the background? So part of the treatment is finding out the individual psychology. Is there depression? Is there anxiety, PTSD, bipolar? Oh my gosh, there's lots of things that we go through in a short period of time. And it is about changing behavior, getting rid of plastics, getting rid of soft drinks and sugars and fructose and all these things. We've been poisoned by the food industrial complex over the last 70 years. And I say, you're going to start today, you're going to reduce your food intake 30%. And then the patient says, well, I'm not eating that much. Then I respond, you're eating too much for your metabolism. You should be losing 2 pounds a week. If you're not, you're eating too much for your biologic state, what your body is doing. And then I use things like a bank account. Are you making too many deposits and not enough withdrawals? So we go through a number of different metaphors so they can build a picture. I have them sign a contract. I have them see a nutritionist. There's a program in the US called ENARA, ENARA. It's an online program that's free for Medicaid people, but costs a subscription for people with insurance. But I tell people when you cut 30%, your food expenditures every month is going to drop 30%. And you can invest that money in a nutritionist or a weight loss program. We teach people how to count calories. They get a scale, they weigh themselves. We aggressively manage their diabetes, of course. GLP-1 or dual agonists like tirzepatide are good for losing weight, but they have a big problem. They all cause muscle wasting. So people should not be on GLPs for more than 1 year, in my opinion. And during that time, you can manage their psychology. So that's really the big package. But if somebody is obese and has fatty liver and hepatitis B or C, you need to treat their fatty liver while you're curing their C or treating their B. Though metabolic disease is about behavior, but you have to understand your patient's psychology. And we don't get frustrated. We just bring them back and we keep doing more and more education.
Hi, Dr. Gish. So one of the things that I was thinking about as you were talking about point of care testing was the amount of accessibility that we're going to have to, specifically Hep C point of care testing, because I know that that's something that's in the works right now. Do you have an estimate for when point of care will be standard of care, as we're moving forward into making sure that, we're trying to reach that 2030 elimination goal?
We have point of care in the US with that finger stick device from the OraSure company called OraQuick, I think it is, but it's not oral. It's a blood finger test on a strip, gives you an antibody result in 15 minutes. The Gene Expert machine is now FDA approved and being placed in various locations around the US because of its utility across many types of infectious disease. So that's a little bit more about penetrance. I think the machine is somewhere around $50,000, but you have to have a laboratory setting where that can be done. But that laboratory setting can be a mini lab and it can be in various locations, and it's a portable machine. You just have to have the right technician running that machine. So we have point of care for C in the US, both for antibody and PCR, what we call nucleic acid testing. Hepatitis B point of care testing is coming. There is one specific company, I'm blanking on the name for just a moment. I think it's Radix, R-A-D-I-X, that's developing a point of care for B that should include surface antigen and PCR testing. So that's going through a full evaluation phase. I think will be available in the US next year, I'm hoping. So those things are good. We're almost there in the US, although we're late to the game because the FDA has gigantic regulatory thresholds that are much more difficult. than getting a CE marked, for instance. The European system, in my opinion, is easier. The FDA is trying to be better. Hepatitis B just got downgraded from a class 3 to a class 2. That should make it easier for point of care companies to develop the test. So I'm optimistic 2026, 2027, we'll have more approvals and more machines.
Thank you, Dr. Gish, for such a wonderful presentation and for being here today. And thank you, everyone, for attending.
Thank you to our rest of our team, HCSF, South Florida. Thanks for your introduction.